Hi guys, welcome back to the Rapid Review lecture series. Today's lecture is about GIT pathology part 2. My name is Namisha Verma and I'm a fourth year medical student, and today's lecture is going to be covering liver, gallbladder, and pancreas. Just to start with, this is a table of contents of all the things I'm going to talk about today in this lecture. So I'm going to start with liver pathology. So before we jump into the pathology, let's just get an overview of the morphological and functional units that make up the liver. So the classic morphological unit of a liver is what we call a hepatic lobule. It's this hexagonal shape that we see on the left side and is made up of one central vein, a portal triad located in the periportal spaces, and is divided into 3 zones. So when we talk about the portal triad, it is made up of interlobular artery, which is a branch of the hepatic artery, interlobular vein, which is one of the branches from portal vein, and bile duct. The functional unit of the liver is formed by something what we called a liver acinus. And liver acinus is this purple structure that you see over here, and it's formed with 2 of the hexagonal morphological units, and it's called the liver acinus. It can be divided into 3 zones. Zone 1, which is the outermost zone and is the first one in contact with the portal triad. So basically, this zone is where all the fresh oxygen-rich blood comes to, and even the fresh nutrition-rich blood from the portal circulation. That's why this zone is given the job of synthesis of glucose, glycogen, plasma proteins, beta oxidation. But we have to remember that this zone is also the first zone to come in contact with the toxic substances, because all the blood that is taken from the portal circulation first comes in contact with zone 1. Then we have an intermediate zone, zone 2, and zone 3. Zone 3 is the closest zone that we see to the central vein. So it's understandable, since it's the zone furthest away from the portal triad, that it is also the zone at risk of ischemia. So the job given to this zone is the job that does not require that much of oxygen, like cytochrome P450 based detoxification, glycolysis, and lipogenesis. Now, the purpose of this slide is not just to give you an overview of liver functions, but to tell you that the symptoms that we see in liver pathologies are simple logic. If you know the functions of the liver, then you are more likely to see all the symptoms that we can see in liver pathologies. For example, bile production and secretion. So one of the main symptoms that we see in liver pathologies is the presence of jaundice, malabsorption because of lack of production of bile, deficiency of fat-soluble vitamins. The next function is metabolism of fats, proteins, carbohydrates. People who have chronic liver diseases are often cachexic and are suffering from malnutrition, muscle wasting. One of the most important job of liver is to get rid of all the toxic substances, that is drugs, hormones that are not needed, uric acid. So, and especially when we talk about hormone metabolism, we are referring to estrogen and other progesterones. And that is why we see a symptom called gynecomastia, that is the unusual development of breasts, especially in males. We can also observe uremia because of the important part that liver plays in the uric cycle. And then it also has jobs such as production of plasma proteins, which explains that when we have loss of liver function, we have loss of production of proteins, mainly plasma proteins, which leads to hypotension and allows the intravascular fluid to enter the extravascular spaces and form edema and ascites. And then liver is also responsible for production of clotting factors, not just clotting factors, which are vitamin K dependent clotting factors, but also protein C and protein S. So we often see bleeding disorders and anemia. And liver is a huge store of iron and other types of vitamins, which explains the vitamin and mineral deficiencies. It is also responsible for immunity because most of the acute phase proteins are produced in the liver. So a person who has chronic liver problems is usually more susceptible to infections. Liver, not to forget, is a huge reservoir of blood because of portal circulation. And therefore, any problem with the liver parenchyma develops a kind of portal hypertension and backflow of blood into other veins. So I hope this slide helps you understand the symptoms relating to the functions of the liver. So this is just an overview of how I have divided the liver pathologies, and I'm going to try to cover most of them. So starting off with circulatory disorders of the liver. Liver is, like I said before, it's supplied not just by the hepatic artery, but also the portal circulation. So the blood enters through both of these circulations and then drains into the liver sinusoids and then drains into the vena cava. So we're going to start with the pre-hepatic circulatory problems, which are mainly hepatic artery thrombosis and portal vein thrombosis. Hepatic artery vein thrombosis is quite rare. You can see it in maybe transplant rejections and a type of vasculitis called polyarteritis nodosa. And next we have portal vein thrombosis. Portal vein thrombosis can arise as a complication of acute appendicitis, which can cause then portal vein inflammation. We call it pyophlebitis. It can also occur in polycythemia vera, any kind of thrombophilic disorders, and also hepatocellular carcinoma. So what we see in pre-hepatic circulatory disorders is splenomegaly, which is usually present without hepatomegaly. And of course, portal hypertension and ascites, because if there is any problem in the circulatory disorders in one place, you often see the backflow load in the place before it. And then moving on to hepatic. In hepatic, it refers to all the problems that are caused to the circulatory disorders because of the damage to the liver parenchyma. So examples can be cirrhosis, centrilobular hemorrhagic necrosis due to heart failure. So if we have heart failure, there is a backflow of blood into the vena cava, which causes the congestion of the blood flow into the liver. And when we mean by congestion, we mean by carbon dioxide-rich blood stagnating in the liver, which can lead to steatosis of the liver. And it gives it a typical nutmeg liver appearance. I have a picture describing the nutmeg liver experience in the next slide, and also sickle cell disease. So what we see clinically is painful hepatomegaly, increased liver enzymes, and also a condition called cardiac cirrhosis. So when we have the formation of liver cirrhosis because of cardiac causes, we refer to it as cardiac cirrhosis. Now, the post-hepatic causes can include Biliary syndrome and veno-occlusive disease. So on first look, these two things may seem quite similar to you, right? But the difference here is the veno-occlusive disease affects the hepatic sinusoidals, and the Biliary syndrome is talking about the veins. What happens in Biliary syndrome is we have thrombosis of the veins. It can occur as a result of complications in pregnancy, polycythemia vera, drugs, hepatocellular carcinoma, and can even arise through idiopathic reasons. Whereas in veno-occlusive disease, we see hepatomegaly, right upper quadrant pain, jaundice and ascites, and it usually arises as a complication to bone marrow transplant. Now, this is exactly what I was talking about in heart failure. You can see this is the nutmeg right here, and you can see the similarities between the appearance, and that's why it's given the name nutmeg liver. And this is how a liver infarction looks right here. You can see that it's very different from the nutmeg liver because it has areas of paleness and the rest of it is fine. But like I said, liver infarction is quite rare because liver has not just one blood supply, but it's also supplied nutritionally by the portal vein. So liver infarction is quite rare. So moving on to inflammatory disorders of the liver, and that's hepatitis. Now, before we jump into the clinical course of hepatitis, I'd just like to brush up on the differences between acute and chronic stages of hepatitis. Main thing to remember here is that acute hepatitis is less than 6 months, whereas chronic is usually more than 6 months. The causes of acute hepatitis can be either hepatitis virus A, B, D, E. It could be drug-induced, or it could also be autoimmune. Whereas chronic hepatitis is usually because of hepatitis B virus, and it can also be super infected with hepatitis D virus. We can also have drugs or hepatitis virus C. Now, the typical courses in both of them, I will go through with you in the upcoming slides. So this slide is mainly just an overview how majority of the acute infections go. So majority of the acute infections, they usually enter the subclinical disease, which is basically you're having the virus inside of you, but you don't show any kind of symptoms, clinical symptoms. And majority of the people, they recover just fine. But in some cases, it can go into acute hepatitis. And then even in acute hepatitis, you can move on to recovery, but in very minor cases, you can develop fulminant hepatitis. Or in some cases, you just become a carrier. In some cases, you can develop chronic state of infection. And in that case, you're usually put on medication for a longer period of time to keep the virus in control. But in some cases, if you have recurrent bouts of acute infection, you can develop cirrhosis. And eventually, cirrhosis puts you at risk for a lot of other things like cancer. So I know there's a lot going on this slide, but what I'd like to focus on is the fact that all of these viruses, we have to know the difference in transmission, because hepatitis virus A is usually a traveler's disease. So it is usually transmitted through fecal or oral routes, and it hardly leads to a chronic infection. It's usually just acute, and people recover just fine. And hepatitis B and C both are transmitted through parental routes, like transfusion or sexual intercourse, or from mother to kids. Severe markers, I'm going to go through them in the next slides. And then hepatitis virus D cannot infect patients on its own, but it's usually a super infection or a co-infection with hepatitis virus B. Hepatitis virus E, it doesn't have much clinical importance, but it's important to remember that it can lead to fulminant hepatitis in pregnant women. So now about the clinical course of the disease. Usually it starts with a carrier state, and in which we do not really show any kind of symptoms, and the virus is barely even detectable. Then we go on to asymptomatic phase. In this phase, the virus is replicating, but there are still no clinical symptoms, but it can be detected on blood tests. And then we have acute phase. Now, acute phase consists of incubation period, prodromal period, and icteric phase. Incubation period is where the virus is just replicating. Prodromal period is where we show very mild symptoms. Very mild symptoms. In icteric phase is where we have a full-blown case of jaundice. So we can see jaundice, which is because of both elevation of conjugated bilirubin and unconjugated bilirubin, with dark urine, fever, nausea, and elevated liver enzymes. Now, when it turns into chronic phase, it can further be divided into a phase of immune tolerance, immune active, immune control, and reactivation clearance. I'd like you to see this diagram over here, and we can see that in immune tolerant phase, there is an increased amount of virus, and the immune system is barely just rising. And therefore, the signs of ALT and AST, which basically tell us about hepatic injury, basically they follow the control, the actions of immune system. So in immune tolerant phase, the virus is what's replicating and the immune system is not yet alerted. In immune control phase, the immune system takes over, and therefore we can see a rise in ALT and AST because it's a marker of hepatic injury. And we all know that the main cause of hepatitis in viral infections is not the virus itself, but the immune system. And so, which brings the virus slowed down. And then we have the immune active phase, which we already covered, and we have immune control phase, where a certain level of control is maintained between the virus and the immune system. And this is the longest phase. If you think about this, is the longest phase that can be maintained. But in cases of immunosuppression, we can have reactivation of the virus. So in chronic phase, the inflammation is dominantly around the portal tract. So if you could see on histopathology, you would see a lot of inflammatory cells around the portal area. And hardly after this, we have the development of fulminant hepatitis, unless you go through a very immunosuppressive treatment or you are very sick. Now, this hepatitis B serology is usually the hardest part of hepatitis for many students. So I've tried my best to make it as clear as possible. So here's a picture of what the antigens are and what the antibodies are and where they're located on the virus itself. Surface antigen, like the name suggests, is right here on the surface. E antigen is something that's inside the virus. Core antigen is located right on the inner capsid wall. And these are the antibodies. So before we jump into when all of those start rising during the course of the disease, let's understand what they actually mean. So we have the surface antigen. Surface antigen is the first marker to appear in the infection. And its persistence beyond 6 months is what tells us that the infection is chronic. As you can see over here, the surface antigen is in the color red, and you can see it's one of the first markers that's rising. And usually it comes down if it's an acute infection. If it's chronic, it would have continued. And then we have antigen E. Now I want you to associate E with infectious, because E is what tells us about the level of antigen E is what tells us about the marker of replication and viral load. So if you have a very high amount of E antigen, you can tell that the virus is highly replicative at this stage and highly infectious. And then we have the core antibodies against the core antigen, and this can be divided into IgM and IgG. IgM is the big pentamer antibody, and it's the first to start with it's the first attack of the immune system. You can see here in blue color, it starts rising. This part is IgM. So it's a marker of recent infection, and it's more likely to disappear after 32 weeks. Next we have is IgG. This most likely is IgG. So basically, IgG is an antibody which is responsible for maintaining the protection against this virus, and it rises after IgM. Next we have is a surface antigen antibody. Surface antigen antibody arises late after the acute infection, and it indicates immunity. So if a person has high levels of surface antigen antibody, it can tell us that they have more likely had an infection previously or they got vaccinated. This table right here is quite important, and I suggest if you can make sense of this table that you really understand the serology behind hepatitis B. Next up, we have alcoholic liver disease. As we all know, it's one of the leading causes of liver disease. Wherein alcohol itself is not that toxic to the liver, what's toxic is acetaldehyde. And acetaldehyde is nothing but the metabolic product of alcohol itself. Now, injury to alcohol is not something that's injury from alcohol is not something that's acute, but rather a chronic process, and can be divided into three stages, mainly, roughly put together. So if we have the first stage is alcoholic steatosis, in which we see centrilobular accumulation of macrovesicular fat. Now, I'd like you to know that steatosis can either be microvesicular or macrovesicular. And microvesicular is seen in diseases such as Ray's syndrome. And macrovesicular we can see here in alcoholic liver disease. So this first stage is usually asymptomatic and it's completely reversible with abstinence. But the second stage, now this is the stage that's the most long and chronic. And in this stage, we have the continual damage to the hepatocytes. And that is why we see an elevation of AST and ALT. And we have painful hepatomegaly, acute inflammation with the presence of Mallory bodies. In this picture right here, you can see Mallory bodies. They're nothing but a collection of damaged cytokeratin filaments. We also see perivenular fibrosis and jaundice, fatigue, fever. Now, this stage is a stage that's hard to come back from. But if a person continues with the abuse of alcohol, they will eventually end up with stage 3, and that is of cirrhosis. And I'm going to cover cirrhosis in detail in the upcoming slides. All right, so this slide is about the difference between alcoholic liver disease and non-alcoholic fatty liver disease. So clinically, they seem quite similar when it comes to symptoms and all of that. But the real difference here is that in non-alcoholic fatty liver disease, it's usually associated with the accumulation of fat inside the hepatocytes. So basically, the liver is being bombarded with more fats than it can process. So clinical characteristics, we often see patients who are overweight, have history of metabolic syndrome, hypertension, diabetes, etc. In laboratory tests, we can see, and this is something that I really want you to remember, and that is in the case of alcoholic liver disease, AST is more elevated than ALT, which is the opposite case in non-alcoholic fatty liver disease, where ALT is more than AST. And of course, they have more things that come along with the liver problems. That's dyslipidemia, increased blood glucose, steatosis, and other things. So basically, non-alcoholic fatty liver disease is a diagnosis of exclusion. So it's not the first thing that should come to your mind, but it's something that's left as an option when nothing else is possible. So on liver biopsies, in both cases, we see steatosis. And the inflammatory process is usually less in non-alcoholic fatty liver disease than in alcoholic liver disease, because the injury to the hepatocytes is more extensive because of acetaldehyde than from accumulation of fats. Next up, we will move on to the inborn errors of metabolism in liver, and an example of that is Wilson's disease. Now, Wilson's disease is an autosomal recessive mutation in the ATPB7 gene, and this gene is responsible for something called the copper transporting ATPase. Copper transporting ATPase is basically a protein which is responsible for taking copper and joining it with epoceruloplasmin. So you can think of it as copper is a passenger and epoceruloplasmin is like a vehicle. And together, when copper is attached to epoceruloplasmin, it's called ceruloplasmin. And ceruloplasmin is what is detected in the blood. So it's a way of the body to attach copper onto epoceruloplasmin so it can be excreted via bile. So what happens in Wilson's disease is, since we do not have this ATPase, copper is not able to get attached to epoceruloplasmin, which means we have reduced levels of ceruloplasmin, and which means we have accumulation of copper. Copper has nowhere else to go because it can't be excreted now. So what it does is it starts accumulating in organs like liver, basal ganglia, retina, and in late cases, it can also affect organs like kidney and enterocytes. And this is something to keep in mind because the triad of hepatitis, dementia, and Parkinsonism is quite unique. Not a lot of pathologies have this kind of triad. So when you see these kind of symptoms, Wilson's disease is definitely that should come to your mind. And Wilson's disease is usually diagnosed in the earlier ages, like from between 20 to 40s. So if a relatively young person comes to you with these symptoms, you have to consider Wilson's disease. Other symptoms can be behavioral changes, tremors, and Fanconi syndrome. This picture right here is called the Fleischer ring. It's because this brown color you see right here is because of the accumulation of copper in the eyes. Moving on to hemochromatosis. Hemochromatosis is a disease in which we have an overload of iron. And the hereditary form, which is the primary type of hemochromatosis, is because of a default in the HFE gene. So the function of HFE gene is to facilitate the binding of transferrin to its receptor. And the activation of receptor is what is going to control the levels of hepcidin that's released. And hepcidin is a hormone which is responsible for decreasing the absorption of iron. So hepcidin is like a control station. It tells the enterocytes, yes, we are low in iron, so you can start absorbing more. And when we have enough iron, it says, okay, stop, no more absorption. So the problem comes when we have a faulty HEF protein. Therefore, the hepcidin does not know how much of transferrin is present in the blood. So levels of hepcidin decrease, and we have an unopposed absorption of iron. Now, there is a certain distinction that is to be made between the primary type of hemochromatosis and the secondary type of hemochromatosis. Secondary type of hemochromatosis is mainly seen in transfusion reactions or increased hemolysis. And in this case, we have increased overload of iron to begin with, which causes an increase in hepcidin. So it's not the body's, it's not the fault of the HEF gene here. As you can see on this picture right here, iron has a tendency to accumulate in many places. So we can see skin pigmentation, it can accumulate in thyroid, hepatic dysfunction, and usually the cause of death in such people is through liver cirrhosis or hepatocellular carcinoma. And the sad thing is that hemochromatosis is diagnosed quite late after there is involvement of organs. We can also have cardiomyopathy. Which kind of cardiomyopathy? Well, a restrictive type, because iron can accumulate in the walls of the ventricles. So we can have a restrictive type of cardiomyopathy, arrhythmias, heart failure, and also diabetes, because iron has an affinity to pancreas, and accumulation of iron in pancreas leads to a very brown color of pancreas. And also we have insufficiency of pancreas leading to diabetes. It has a special name called bronze diabetes. Iron can also accumulate in different joints in the body, leading to arthropathies and hypogonadism. Moving on to biliary cirrhosis. Biliary cirrhosis is one of the biliary causes of liver pathologies. And there are several different types of reasons of obstruction in the biliary tract that can lead to problems with the liver, but I'd like to focus on primary sclerosing cholangitis and primary biliary cholangitis. When we talk about PSC, it's a progressive chronic inflammation of both intrahepatic and extrahepatic bile ducts, whereas primary biliary cholangitis is a progressive destruction of only intrahepatic small and medium bile ducts. Where primary sclerosing cholangitis is more common in men, primary biliary cholangitis is more common in women. So it's understandable because it's an autoimmune disease. And women are more predisposed to autoimmune diseases than men. So when we talk about laboratory tests, they are usually quite similar results. For example, they have an increase of ALP. We have an increase of ALP here as well. We have an increase of GGT, conjugated bilirubin. What's the main difference is the presence of P-ANCA and the presence of anti-mitochondrial antibodies in primary biliary cholangitis. Also, they are associated with different conditions. Primary sclerosing cholangitis is associated with ulcerative colitis and cholangiocarcinoma, whereas primary biliary cholangitis is associated with other types of autoimmune conditions. Now, one more thing to help you understand better is their clinical course of progression. Primary sclerosing cholangitis, since it affects both intrahepatic and extrahepatic bile ducts, the prognosis is way worse than in the case of primary biliary cholangitis. But, however, since primary biliary cholangitis is an autoimmune condition, even after liver transplant, it can reoccur. Whereas in primary sclerosing cholangitis, liver transplant is usually curative. Clinical presentation of both of these conditions is quite similar. We have the presence of pruritus, fatigue, jaundice, hepatomegaly, and of course, the presence of other associated conditions. Now, this is a picture of a procedure called ERCP. It stands for endoscopic retrograde cholangiopancreatography. And on this side, you can see how normal bile ducts look. There are no strictures, it's completely normal. And on this side, we can see what a sclerosing cholangitis looks. You don't have to be good at radiology to spot a difference because you can see there are several strictures over here. Moving on to liver cirrhosis. Now, liver cirrhosis refers to an irreversible diffuse fibrosing of the liver parenchyma. And like I mentioned earlier, it is usually where all the chronic liver diseases eventually lead up to. Chronic liver damage, chronic injury to the hepatocytes lead to activation of Kupffer cells. Kupffer cells, we know they're just a different type of macrophages that live inside the liver. And once Kupffer cells are activated, they themselves start the destruction of hepatocytes, which can trigger repair mechanisms. So when hepatocytes are destructed, they start sending signals for repair mechanisms. Basically, what they do is they activate cells called the stellate cells. Stellate cells are usually present in a very inactive form, and once activated, they produce a lot of excessive collagen production. Apart from this, activation of Kupffer cells can also lead to the activation of other inflammatory pathways that can lead to more destruction and presence of more leukocytes and neutrophilic cells. Over here, we can see that the liver cirrhosis, it completely destroys the parenchyma of the liver. We saw a very good hexagonal shape of a healthy liver, but in the case of liver cirrhosis, the entire hepatic parenchyma is divided into regenerative nodules. So we have bands of fibrosis right here, and then we have a regenerative nodules in the center. Etiology, like I described earlier, many chronic conditions like alcoholic liver disease, viral hepatitis, biliary diseases, hereditary chromatosis, Wilson's disease, drugs, and different kinds of other chronic insults to the liver. Now, liver cirrhosis has a lot of complications, and I have tried to cover the most important ones like portal hypertension. Portal hypertension, like we already described in my first few slides, can lead to a backload of flow into the other veins that make up the portal vein, especially the vein from spleen. And therefore, we can have the presence of splenomegaly. We can also have the presence of ascites. And if we have stagnation of fluid in the peritoneum, and especially in the case of people who have chronic liver problems, they have a chronic presence of ascites and they're at higher risk for spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis can lead easily to sepsis. So that's something that doctors always check for. And then it can also lead to the formation of esophageal and abdominal varices, rectal hemorrhoids. Again, these are also very high risk complications because bleeding from these varices can easily progress to shock. So that's something that doctors always look out for. Then we can have a bleeding diathesis. So that means more tendency to bleed because of the absence of coagulation factors. Now you can see that this image can form in your head that when people have portal hypertension and formation of ascites with bleeding diathesis, they're at very high risk of hypovolemic shock. We can also have presence of hepatic encephalopathy and development of Hepato-Renal syndrome and hepatopulmonary syndrome. What we mean by Hepato-Renal syndrome is the decline in renal function because of liver causes. So when we have portal hypertension and ascites, the fluid from intravascular areas is moving into extravascular areas, and that's decreasing the perfusion to the kidney. And a decrease in perfusion of the kidney can lead to acute renal failure. And that's the sign is anuria. So that's something to keep in mind because hepatorenal syndrome is where we have problems with the kidney because of liver causes. Hepatorenal syndrome is problems in the lung because of liver causes. For example, we have severe hypoxemia due to dilation of intrapulmonary vasculature. When we have dilation of intrapulmonary vasculature, the partial pressure of oxygen goes down, leading to severe hypoxemia. Next up, we have hepatocellular carcinoma. Like I said, in all chronic liver diseases, we always have a chance of development of hepatocellular carcinoma because I think in any organ, if the cells are being injured, they need to activate their repair mechanisms, and the more activations of repair mechanisms, there is something bound to go wrong, give a rise to a mutation, and we can have the development of cancer. Now in this slide, it's just a few pictures that are seen in people who have liver cirrhosis or chronic liver disease. Here is what I was talking about when I said esophageal varices. And this is something we call spider angiomata. It's one of those things that you rarely see, but you can sometimes see it in people who have cirrhosis. This picture over here is it's a very typical picture of what people with liver cirrhosis look like. You can see they are very cachexic because of the malabsorption and malnutrition, which has been probably going on for months or even years. You can see the formation of ascites. And if you look closely, you can also see the formation of abdominal varices. And over here, you can see the difference between normal liver parenchyma and what a cirrhosed liver looks like. The presence of nodules. There are no nodules present on the normal liver. All right, next up is jaundice. Now, before we jump into jaundice, let's go through the bilirubin metabolism pathway. So we have hemoglobin, which is present in the erythrocytes, which is when erythrocytes get old and they don't work as well, they get stuck in the spleen where they are broken down, and hemoglobin is broken down into heme and globin. So globin is a protein, it can be reused and metabolized quite easily. And what happens with heme is that it's converted into biliverdin and then bilirubin. Now, bilirubin is not water soluble, so it needs to be attached to a protein in order for it to be released into the blood. And that protein is albumin. So we have a complex of bilirubin and albumin, which is released into the blood, which enters the liver and is conjugated. The process of conjugation, the aim of the process of conjugation is to make it water soluble so it can be excreted. So bilirubin is conjugated at this point and then released into the bile, where it then goes to the intestines, and in the intestines it's converted into urobilinogen. Now, urobilinogen can either get converted then into stercobilin and get excreted into the stool, or it can re-enter the bloodstream and go all the way to the kidneys to be excreted into the urine. So over here on this side is a big list of all the things that can possibly cause jaundice, or at least I've tried to include the most important causes of jaundice. So we're going to start with increase of hemolysis. So if you have increased amount of bilirubin produced to begin with, we can have the presence of increased unconjugated bilirubin in the blood. Causes include hemolytic anemias, blood transfusions, thalassemia, pernicious anemia, or just internal hemorrhage. The next problem we can have is at this point where we have decreased of uptake of bilirubin, and that can be because of some drugs like rifampicin or sulfonamides. The next problem can arise in impaired conjugation at the level of liver. Especially it is seen in Gilbert syndrome and Crigler-Najjar syndrome. They're quite similar. In Gilbert syndrome, we have the reduced activity of this enzyme called UGT. It's UDP glucuronate transferase, which is responsible for the conjugation itself. Oops. Yep. So in Gilbert syndrome, we have the reduced activity of this enzyme, and in Crigler-Najjar syndrome, we have the complete absence of the enzyme. All of the causes that I've mentioned up until now, you have to remember that they are before the conjugation or in the process of the conjugation, and therefore we see a rise in unconjugated bilirubin. And where? In the blood, right? Next up, we have impaired excretion from the hepatocytes into the bile caniculi. So hepatocytes did their job, they did the conjugation, but the problem is in the secretion of bile from the hepatocytes to the canaliculi. And that's the case of Dublin-Johnson syndrome, Rotor syndrome, when there is an absence or mutation of the transport protein that is responsible for the movement of bilirubin from the hepatocytes to the bile canaliculi. Next up, we have biliary tract obstruction or disorders. Like I said, I've already explained primary sclerosing cholangitis and primary biliary cholangitis. We can also have obstruction due to gallstones, strictures, cholangiocellular carcinoma. And since all of these causes are after the conjugation process, we can have an increase or elevation in conjugated bilirubin in the blood. Now, to further explain this, we have in these disorders, we have an increase in unconjugated bilirubin in the blood, not in urine, because it never got the chance to be turned into urobilinogen. And so we have increase of conjugated bilirubin in bile. So when we talk about unconjugated bilirubin, it is insoluble in water and it has nowhere to go. So basically it's stuck in the blood and it's waiting for its chance to be conjugated. So that is why we have an increase in the conjugation and increase in the conjugated bilirubin in bile, which is causing the dark stool. And then we have increase of urobilinogen in urine, not conjugated bilirubin, but urobilinogen in the urine. Cholestatic enzymes in this case are quite normal. Then we have conjugated hyperbilinuronemia, in which we have increase in conjugated bilirubin in the blood and urine. So this bilirubin was already formed in the liver, but it never got the chance to reach the intestine. So that is why the conjugated bilirubin had nowhere to go but to enter the bloodstream. And since it is water soluble, it can also enter the kidney. Therefore, we see the conjugated bilirubin in urine. Please make the distinction that in this case we see urobilinogen in the urine, but in this case we see conjugated bilirubin in the urine, giving the urine the characteristic dark color. So there is no bilirubin in the bile. That is why we have pale stools. And there is an elevation of cholestatic enzymes because the problem may or may not lie in the biliary tract itself. We can also have an elevation of both unconjugated and conjugated bilirubin in the blood in the case wherein the destruction is at the level of the liver and the biliary pathway. So conditions affecting both the hepatocytes and the bile drainage system can often lead to a hyperbilirubinemia that has elevated levels of not just conjugated but also unconjugated bilirubin. For example, in the case of hepatitis, cirrhosis, hepatocellular carcinoma, and typically we see pale stool, dark urine, and elevated liver enzymes. Now, these are also some of the symptoms that can be seen in the case of jaundice. Typical sign we see is the yellowish color in the sclera, formation of xanthomas, and pruritus. Now, in pruritus is mainly caused because of the release of bile acids in the blood, and bile acids are quite irritating to the nerves. So basically, people who have mixed hyperbilirubinemia or conjugated bilirubinemia, they have an intense urge to itch. Next up, we have pathologies of the gallbladder. Now again, since I already covered some of the biliary causes of liver pathologies, I have decided to focus on cholelithiasis and some other pathologies that are just specific to the gallbladder under this section. So, cholelithiasis refers to a presence of abnormal concretions in the gallbladder. Now, any imbalance in bile salts, cholesterol, phospholipids, bilirubin, or stasis can potentially lead to the formation of stones. Now, as you all may know already from either physiology or histology, that the function of the gallbladder is not just to store the bile, but also to maintain the contents of the bile. And in the case of cholelithiasis, if we have any imbalances in the bile salts, level of cholesterols, it can lead to the formation of stones. Now, there's a very good mnemonic for the etiology, and that's the 4 Fs, referring to fat, obesity, 40, age, female, the female gender, because estrogen and progesterone, estrogen causes a release of cholesterol-rich bile, and progesterone causes the relaxation of gallbladder. That means stasis. It supports stasis, which is definitely one of the contributive factors to the formation of stones. And fertility, again, in pregnancy, we have a rise in the levels of estrogen and progesterone. Both of them, they are enhancing the formation of stones. And we also have family history. Now, the clinical features that are observed are usually patients with cholelithiasis are quite asymptomatic, but they can have biliary colic. Biliary colic is a pain that is specific to cholelithiasis. It's a dull right upper quadrant pain lasting less than 6 hours, and sometimes only with contractions of the gallbladder. They may also have nausea or vomiting. And here on this side, you can see the pigmented stones are usually the case where the bilirubin is high. And calcified stones, if there are any changes in pH, it can lead to the precipitation of calcium from bile and lead to calcified stones. Cholesterol gallstones here is because of increased level of cholesterol in bile. Now, in this image, you can see that usually gallstones, they just lie in the gallbladder and are completely asymptomatic. But in some cases, especially after food, where there is cholecystokinin released, it can lead to intense contractions of the gallbladder, and sometimes this stone can end up being lodged in the neck of the gallbladder. Now, there are several things that can happen from this point onwards. One of the thing is either it can go back to normal, it can drop back into the base of the gallbladder and it becomes normal again, or in this area, it can press on the blood vessels, leading to ischemia, and also the formation of something called hydrops, wherein the mucosa of the gallbladder starts secreting a lot of mucus because it's getting ischemic, so we have vasodilation of the vessels and it's leading to the more increased formation of mucus, and that's what we call hydrops. So after this point, the gallstone can go back to its position and we can have reperfusion, or what it can happen is the worst case scenario, it can precipitate cholecystitis, which is the acute inflammation. Other complications can be cholecystitis, choledocholithiasis, acute pancreatitis, biliary enteric fistula, obstructive jaundice, gallbladder cancer, or even ascending cholangitis. So when we talk about cholecystitis, first let's make a distinction between acute and chronic cases of cholecystitis. In acute, we can differentiate between calculous cholecystitis or acalculous form. Now, acalculous is actually quite rare, and you see them usually in critically ill patients, patients who are already in multiple organ failure or right after a very invasive surgery, severe trauma, etc. Clinically, they present quite similarly to the calculous form. And calculus form, it's usually the most often the case, and it's because of obstruction to bile flow, which leads to stasis and allows bacterial overgrowth, which further leads to inflammation, pain, and ischemia. Again, the clinical signs you will see are quite similar. We have right upper quadrant pain, fever, and Morphy's sign, which is basically pain with deep inspiration. So movement presses against the liver, and then we have pain. Chronic cholecystitis is because of either long-standing cholelithiasis or long-standing stasis. Because of all the contents of the bile, they can be quite irritating to the mucosa of the gallbladder, or it can be because of recurrent attacks of acute cholecystitis. And in the case of chronic cholecystitis, we can have formation of porcelain gallbladder, which is basically fibrosing and calcification of the gallbladder, and it cannot contract as usual. And the pain over here is quite vague and often after eating. Now, other complications is ischemia, typically leading to gangrenous necrosis, which is usually what happens. And the next we have is gallbladder perforation, which can eventually progress to peritonitis and then sepsis. Now, this is a figure, and I've tried my best to explain how ischemia can happen. So when we have the when we have the contraction of the gallbladder and the stone gets lodged up here and leads to stagnation of the bile, which allows the growth of bacteria, which can lead to inflammation of the gallbladder. And that inflammation can be caused because the inflammation can press on the blood vessels around the gallbladder, leading to ischemia. We can also have the formation of cholecystoenteric fistula. That is, it can perforate the wall of small intestine and have an abnormal opening or communication between these two. We can also have formation of hepatic abscess. Now, if we have the growth of bacteria, the bacteria can ascend all the way to the liver and lead to hepatitis and formation of an abscess. We can also have gallbladder cancer or choledocholithiasis. Choledocholithiasis is when the stone is lodged in the common bile duct, as in the case here. I have more information on choledocholithiasis in the next coming slides. So in the case of choledocholithiasis, like I explained, it's when the stone gets stuck in the common bile duct. As you can see here, it's a picture of ERCP, and here is where the stone is usually stuck. So the risk factor is, of course, it makes sense, long-standing cholelithiasis, and clinical features are usually quite same, except here's the difference where it has prolonged intense pain. The pain is usually more intense and is prolonged more than 6 hours versus the short pain we see in gallstones. We have nausea, vomiting, anorexia, signs of extrahepatic cholestasis, and can also present with features of complications. So it's not just necessary that they arise with the pain that is present in cholelithiasis and is quite typical, but sometimes it can arise with features of complications, which I'm going to discuss. So we can have Gallstone Alias, when the stone, like I described here, in the case of perforation, the stone can get inside the intestine, or the stone can just move through the bile pathway into the intestine and cause an obstruction around the stone, leading to ileus pain. We can also have acute pancreatitis. Since pancreas also opens into this common bile duct, if the stone gets lodged in this area, it can block the secretion of pancreatic fluids, which can lead to acute pancreatitis. Now, the important thing to remember here is that acute pancreatitis can not only be caused because of the reason I just described, but also because of the procedure ERCP itself. We can also have acute cholangitis because bile flow is responsible for washing out all the bacteria that's trying to ascend all the way up from the intestine. And if there's stasis of bile and the flow of bile is obstructed, it can give an opportunity for the bacteria to ascend all the way up to the liver. So we can have acute cholangitis, acute cholecystitis, and also presence of liver abscess. Now, this slide is not really important for you, but it's so that you get an image that in the case of cholelithiasis, we don't have a very concrete testing procedure. So we have something called risk stratification, wherein based on the symptoms, we can assess the likelihood of someone developing cholelithiasis. Because like I said, ERCP is a quite risky procedure, and the procedure itself can precipitate acute pancreatitis. So we usually look into this risk stratification table to assess whether how likely it is that the patient will develop cholelithiasis. And in that case, we can just go through gallstone removal. Now we're almost done with all the pathologies I planned on covering for liver and gallbladder. So this slide is just to give you an overview of the liver function tests. Now, it's important to keep in mind that when we talk about liver function tests, it's not just the enzymes I'm talking about, but also the synthetic function of the liver. That's bilirubin, INR, and albumin. But in this slide, I want to focus on the enzymes. So when we talk about hepatic injury, we have a very predominant elevation of AST and ALT. We could have a slight elevation of GGT, but in the case of hepatic injury, it is usually just AST and ALT. But it's important to remember that if you have a very high elevation of AST and ALT and a very high elevation of GGT, that it could be a case of chronic alcohol abuse, because alcohol itself is also responsible for an elevation of GGT. In the case of cholestatic injury, we have a predominant elevation in ALP and a predominant elevation in GGT. And elevations of AST and ALT may or may not be present depending upon how intensive the injury to the hepatocytes is. So it's also important to remember that ALP is not very specific to cholestatic injury because it is also elevated in some of the bone diseases. So again, it's important when we talk about testing for liver pathologies, it's important to focus not just on enzymes, but also the synthetic function. We do blood tests, we do several types of imaging methods, and only then we come to a diagnosis. But the aim of the slide was just to give you an overview of the elevations that can take place and what they suggest. All right, we're almost at the end of the lecture, and now it's time for pancreas. So I have decided to focus on some of the major pathologies of pancreas that you absolutely need to know for your exams. and that's acute pancreatitis. Acute pancreatitis is an emergency situation, and the patient is in lots of pain and it progresses very fast. So, diagnosis is key in this case, and then treatment should be started as soon as possible. Acute pancreatitis is an acute inflammatory condition of the pancreas, most commonly because of biliary origin or alcohol abuse. Diagnosis is mainly based off clinical presentation, ultrasound, blood tests, and in blood tests, we're looking for enzymes like the lipase and amylase. But for your exams, I highly suggest you know all the causes of acute pancreatitis since it's such an important emergency. So it can be idiopathic, gallstones, ethanol, trauma, steroids, mumps, autoimmune, and all of these other conditions like hyperlipidemia, ERCP, or even drugs. So the clinical features that we see in acute pancreatitis are constant severe epigastric pain, nausea, vomiting, jaundice, ascites, and we really need to look out for signs of shock because, like I said, acute pancreatitis is an emergency and it can progress really quickly to shock. And these are, as you go upper in the years, you need to know the symptoms of shock. They're very important: tachycardia, hypotension, oliguria. Now, very quickly, I'm sure you've covered the pathophysiology of acute pancreatitis under physiology, but I'm very quickly going to give you an overview of how this situation is precipitated. So here you see, this is what a normal healthy pancreatic lobule is supposed to look like. But insults such as alcohol and tobacco can lead to activation of proteolytic enzymes inside the pancreas or inside the ducts of the pancreas, which can lead to a destruction of pancreatic parenchyma. And once we have destruction of the pancreatic parenchyma, the immune system is alerted, and then we have attraction of inflammatory cells and release of a lot of cytokines, interleukins, and other factors. So once the proteolytic enzymes are activated, we have to keep in mind that because of the inflammation, there's histamine being released and we have vasodilation. So which means that these enzymes can escape into the blood flow, which means that the enzymes can affect not just pancreas, but also organs such as the lungs, and therefore, and the whole circulatory system. So we have damage of vascular walls by pancreatic enzymes, which can cause DIC, disseminated intravascular coagulation, shock, multiple organ failure, and also if they get inside the lungs, we can have formation of ARDS. So here's a quick overview of several complications. We can have the bacterial superinfection because of formation of pancreatic necrosis. We can have a superinfection on the dead and necrosed tissue, which can progress to sepsis. And then we can have the formation of a pancreatic pseudocyst or abscess. We can also have fatty necrosis of the pancreas, and fatty necrosis has a tendency to attract calcium, leading to hypocalcemia. And we know that hypocalcemia can have several effects on the heart. It can cause arrhythmias. Like I mentioned earlier, it can escape and attack the lungs, leading to pleural effusion, ARDS. We can also have DIC and shock. And acute pancreatitis, if handled well, can convert into chronic pancreatitis, or chronic pancreatitis can also happen on its own because of chronic heavy alcohol abuse, or it can be autoimmune, or because of systemic diseases like cystic fibrosis. Clinical features of chronic pancreatitis are quite different from acute ones. Usually they are just asymptomatic. And what you see is over a long period of time, you see a decline of the pancreatic function. So depending upon the functions of the pancreas, you can think logically that we are going to have steatorrhea, weight loss, impaired glucose tolerance, and malabsorption. In this picture right here, you can see the different complications that can arise because of chronic pancreatitis. We can have formation of pseudoaneurysm, bleeding, formation of a pseudocyst, And because of the fibrosing of the pancreas, we can have an obstruction to the biliary path, biliary tract. We can also have duodenal obstruction. And because of the pressure it's going to put on the venous circulation, we can also have formation of venous thrombosis. We can have formation of ductal stones because the fluid inside is allowed to stay in there for longer. Yes, so I tried completing all the complications. Of course, there are more. So my sources were AMBOSS, Osmosis, Rapid Review Pathology by Edward Golian, Fundamentals of Pathology, and I highly recommend all of these sources. They're amazing, especially AMBOSS. It's totally worth it. So yeah, that was my presentation. Thank you so much for staying till the end of it. I know it was quite long. And if you have any doubts or any questions, you can either email them to me or you can just drop them in the comments below. And one last thing, please fill out the feedback form via the QR code, via the link that is mentioned right here. And thank you, and have a nice day.